本日はご参加いただき誠にありがとうございます。ただいまよりランチョンシンポジウム Future Perspective of Obstetric Anesthesia in Japan を開始いたします。座長の昭和医科大学医学部麻酔学講座加藤理恵先生、よろしくお願いいたします。
はい、皆さんこんにちは。Good afternoon. Welcome to the luncheon session titled Future Perspective of Obstetric Anesthesia in Japan. I'm Rie Kato from Showa Medical University, and I'm chairing this session. This session is sponsored by B. Brown S Club, and I'd like to express my great gratitude to B. Brown S Club. And we have 3 outstanding speakers today. And they talk about OB anesthesia in Belgium, the United States, and Japan. Yesterday, at the welcome dinner, Professor Noella Lucas said that Japan and the UK are geographically distant from each other, but we have many things in common than we would think. So we can learn each other from, we can learn a lot of things from each other. I really felt I strongly agree with her idea, and that's what this session is about. We can learn a lot by international collaboration. Belgium, the United States, and Japan are really distant from each other, but we have many things in common than we would think, so we can learn from each other. But the need for the OB anesthesia in Japan is growing rapidly. So we are facing a really critical phase to reshape OB anesthesia in Japan. So this session will give us insights to think about our OB anesthesia in the future. Before I introduce the first speaker, let me explain about this APRI. Probably you have this QR code in your hand, and you can input any questions either in Japanese or English during this session. And hopefully the AI will give us a good translation to both to the speakers and to me, and they can answer the questions or they can answer your comments. So please try this QR code if you've got a comment or questions, please. So, I'd like to introduce the first speaker, Dr. Sarah De Breu from Belgium. Sarah De Breu, MD, PhD, is a consultant anesthetist at UZ Leuven, Belgium. She has specialized in obstetric and pediatric anesthesia with a particular focus on the effects of anesthesia on the developing brain. Dr. De Breu has published extensively and has lectured at national and international conferences. She completed her PhD on new anesthetic strategy for pediatric and fetal interventions aimed at improving hemodynamic stability and neurocognitive outcomes. In her lecture today, she will share the realities and lessons of labor analgesia in Belgium, offering insights that will be really invaluable to us. So please come to the podium, and Sarah. And her lecture title is Evolution of Epidural Analgesia for Labor Delivery in Belgium. Please go ahead.
So I'm very, very happy to be here and give my insights on the evolution of epidural analgesia for labor in Belgium. I've got no conflicts of interest whatsoever, but I am an OA executive board member, and I have been invited here by the company of Brown. So this is where I come from. This is the world map, and I'm living in western of Europe, which is there. And in the middle of there is that's called Belgium. And there is where Leuven is, our university, and it's in the middle of Belgium. It's very old university. It's been there for 600 years, and this is the library, the university library. And a very, very known pathologist had been educated there. He is like the father of the human anatomy. It's Vesalius, and he wrote this first Bible of the human body. And besides that, this is our hospital. It's a little village into the town. It's a 2,500 bed hospital, and we have about 2,500 to 3,000 deliveries every year. And besides that, I think people know us all over the world because we're known for the best chocolates in the world, the best fries. They're not French, they're Belgian. And we also have a brewery in my home city, what is Leuven, and that's where Stella has been brewing for years. So, but now I'm here in Japan, and I'm joining your annual meeting of the Japanese Society of Obstetric Anesthesia and Perinatology, and I'm very happy to be here. And I will explore the evolution in labor analgesia in Belgium. So, before we look at epidural techniques themselves, it's important to understand the real nature of labor pain. Labor pain is often described as one of the most intense human pains. It's not only because of its intensity, but it's also because the pain changes during labor. So, during the first stages, we know that the cervix, when it dilates, the pain is mainly visceral, and it changes during labor, and it becomes more when it starts to stretch the perineum. The pain carries through lower roots, nerve roots, and so it's more. It will change. It's dynamic. It evolves during the complete progress of labor, and this is a key reason why effective analgesia techniques must be adapted across all times of labor. So when we look at the history of labor pain, it becomes clear that the attitudes towards childbirth pain have been changed over the centuries, and for a very long time labor pain was culturally and religiously accepted as something a woman has to go through because that's nature. And I don't think this is still we as women still think it's just nature. It is painful, but in many traditions, it was even interpreted as a moral of spiritual obligation that we have to go through this, and it is, and that is often rooted in religious. So. Before the development of modern anesthesia, people relied on whatever they had available. So they had herbs, they had opium, they had alcohol. So they had the old women would teach the young women and help them go through labor. But it wasn't very effective. And but when obstetric anesthesia was introduced around the 19th century, it was not accepted as really something good. There was a strong religious resistance, and even in Europe, the first women that had labor pain assistance, so labor analgesia, were put on the fire. So we came a very long way, but I think now, and this was launched only this year, that the WFSA launched a declaration on labor analgesia, and that every woman's got the right to have some help for the pain, the labor pain. So especially there is still a problem in the low and middle income countries, but all women deserve respectful, safe, and positive birth care. So it is important that we try to get the same level of help for all women all over the world, and that we try to resolve the major inequity that is still there globally. So that comes to my talk, and if we look at the history, this slide gives a very simplified overview of how labor analgesia has evolved over the past 2 centuries only. If we look back at the early 1800s, options for pain relief were extremely limited, and they were only available to very limited people. And now it is for most women. If we look in the present, the landscape has completely changed now. Our goal is comfort without compromise. So every woman should feel safe. Labor analgesia should be flexible and, especially very important, patient-centered, what the patient wants. This timeline highlights some key milestones in the development of modern anesthesia. You see, only in 1846, ether anesthesia was introduced in this world, and only a year later, chloroform was used to blunt obstetric pain. And what was groundbreaking was that in 1853, Queen Victoria of the UK had her baby with labor analgesia. She already received chloroform for the birth of her 8th and her 9th child. And her acceptance of obstetric anesthesia helped to reduce the cultural and religious resistance that was there until then. So then this was followed by epidural, first caudal epidural analgesia, and then it evolved quite rapidly in the beginning of the 20th century, where the modern technique was introduced first by Fiddle Pages with a lumbar epidural. Later on, there was the loss of resistance technique that came along, and things evolved quite quickly from then, with introducing the 2 needles around World War II, where we could introduce catheters into the epidural space from then. And by the 50s, 60s, epidural labor analgesia became increasingly popular. And then there was a little layback when Antonox was also introduced for labor analgesia, and things evolved really quickly from then. So in the between 50s, 60s, all kinds of local anesthetics were developed, and also epidural morphine was used for the first time as well. And Belgium did play quite an important role in the evolution of, once the technique was around, there was a very important person in Belgium that was trying to do a lot of research on epidural analgesia, and that's why we were quite quickly on the train of labor analgesia, I think. So from the 80s onwards, we enter an era of truly modern regional labor analgesia, and during this this period, a lot changed in what we were giving for labor analgesia and how we would give it. So that's what I'm going to try. In 5 minutes, we try to go over the evolution in how evolved the solutions that we're giving, with entering the opioids into the epidural space, and also changing local anesthetics from previous local anesthetics to ropivacaine. And then we will speak a little bit about how we give it. So in this slide, you see Albert von Steenbergen, which was one of the pioneers in obstetric anesthesia, and there is still a lecture at the Ezra every year that's dedicated to him, because it's the first major evolution in epidural labor analgesia, using low concentrations of bupivacaine. until then, we were used to have high concentrations epidurals for example, postoperative pain relief. We only need to block a few levels, but as I explained in the first slides, we need an extensive block during the labor. So giving a more diluted concentration of local anesthetic will give us a better spread and more routes that can be anesthetized without compromising too much the mobility of our patients. It came to a very large series of more than 3,000 deliveries. And I can say in those years, getting a publication was much more difficult than it is now. So, and they saw that in those patients, using the very low concentration as we use them now gives an effective, safe analgesia and less motor block than they were used to. But until then, they had to give like the every hour top up. So we needed a lot of people. So not many women could have the profits of this epidural analgesia because we needed nearly one anesthetist for every laboring woman. But to show that this is still an evolution that is still important, this is only a publication from last year, 3 years ago, and they looked at even getting lower in the concentrations than we did up to now, and it's still got some positive effects. So you see, if you lower your concentration for labor analgesia, your total consumption of local anesthetics will come down, and your rate in spontaneous delivery will be better, with more physiological births and less need of instrumental deliveries. The duration of labor will be shorter, and the analgesia and the maternal satisfaction will be as good as having a very, very dense block. And it also favors the neonatal outcomes. So these implications support the shift towards ultra-low concentrations. So this is the message that has been around for a long time, but still very up to date. But knowing this, we still need to top up very regularly to have the same amount of pain relief. So looking at adding opioids, that was also not done in the beginning. And it was the same Albert van Steenberg, a Flemish anesthetist, that introduced the first studies about it. And what did they see? That it gets even better. The low concentration, adding opioids, it's also, the onset time will be sooner. The quality of analgesia will be better. The total dose of bupivacaine needed was lower, less motor block, but it came with some itching. So still motor block and still manual top-ups needed after 1 hour. Then it only was a few years later that a new local anesthetic was developed, and this is Mark van der Velde, probably known by a lot of. He was my former boss, and who is still my colleague on the labor ward in Leuven, and he determined the optimal dose for ropivacaine, and we saw that if we used ropivacaine instead of bupivacaine in a quite low dose, that we had less motor block. So that's another thing that was better for labor analgesia. People can move their legs, they've got their strength until the end of labor. But also resulted in less instrumental deliveries. So that is what the evolution, diluted solutions is important. You have to add some opioids, and ropivacaine is probably the best local anesthetic to use for labor analgesia. But then we come to the evolution of how we would give it. You all know that there are different kinds of methods to initiate labor analgesia. We've got the simple epidural analgesia, which is around for a very long time and is very effective, in which we just put a needle into the epidural space, and we will put in a catheter and give the local anesthetic in the epidural space. A CSE is when we put an epidural needle into the epidural space, introduce a spinal needle into the CSF, and give some local anesthetics there to speeden up the labor analgesia, and then put a catheter in the epidural space. And then there is some new technique, I don't know if you use it already in Japan, it's a DPE technique, where we put a needle in the epidural space, we introduce our spinal needle to make a little hole into the dura mater, and then we will give the local anesthetic in the epidural space, and we hope that a little of it goes into the spinal space where it can give his analgesia. So these are the 3 techniques for initiation of labor analgesia. And I think if you look at CSEs and you see that it gives superior analgesia if we think it's superior to have a faster onset, it gives a better sacral spread, it gives less unilateral blocks, and you see that your amount of epidural top-ups is lower. We've got less block failures and we've got less catheter failures, but it comes with some minor adverse events. We see more pruritus. We see if you've got high dose of opioids, you will see there is more fetal bradycardia and there is a little bit more of hypotension. And we've got an untested catheter, and the risks are not higher using a CSA. It's very surprising even that the incidence of PDPH when using a CSE is lower. And if we look at the DPE, I don't think at this time there is a recommendation because there are not studies enough, and all studies came from more or less the same institutions. There is a lot of discussion around if we have to advocate this new technique, and we don't think so. These are very recent studies, just to show you that the discussion of which is the optimal initiation of labor is still around. And I think every method is valid, and it's just you have to make sure which kind you would like to use. Yes, I will. And there are like different schools advocating one over the other. And another thing we have to speak about is the maintenance of labor analgesia. And there has been an evolution, as I told you before. With first manual epidural top-ups, we only could do it, but it comes with peaks and valleys. So it will pain-free, and then the pain will come back. And then we had a very long period that we just added a pump. There was like a continuous infusion, but that resulted in a lot of motor block. And then we had the combination between a continuous infusion and a top-up, which also gave still some breakthrough pain, and still we had a motoric block all the time if you give a continuous infusion. And so we now know that having intermittent bolus is the best way to do it. If you give it by only PCEA modus or a PIEB modus, that's more or less the same. This was first an Italian who came up with a PIEB program. We can discuss about it in the discussion later on, but we see that the big boluses are the key to have less motor block with less instrumental delivery that comes with it. And also, this is just showing that there is no difference if you give a big PCEA bolus or a PIEB bolus. That's exactly the same. It's just that you have to give big amounts. So what was the evolution in Belgium? Very quick, we can say it's a survey we performed last year, and you can see that in Belgium now about 52% are having a standard epidural for initiation of labor, and about 48% got CSE for initiation of labor analgesia. 85% of people are using the low-dose ropivacaine concentrations with sufentanil. And then if we look at to continue labor analgesia, we're getting out of the continuous infusion now. Only 10% is still using it. And so about 90% is using the large doses, which is pretty good. So the Flemish anesthetists understood the message. So the high volume boluses are the right way to work on it. So we can conclude for initiation of labor, we use a CSE and it goes really fast, but epidural is as good. We use ropivacaine, low concentration with Sufenta, and this will result in good analgesia. And then for maintenance labor analgesia, we do need large boluses. It can be done by PCEA or large volume PCEA or PIEB. It's just you need the high volume, low concentration regimens. So I really, really want to thank being here. 2017, I was invited by Dr. Terui at the fetal meeting. That's where we get to know Shohei, and he came to our labor ward, and he was introduced in our hospital, for example, and witnessing how we did cesarean sections and all our labor analgesia. I hope he had a good time there. We really loved him, and we were sad to say goodbye to him, but I was really, really happy to be here, and I want to say thank you very much for having me here.
Thank you so much, Dr. Debru. We're going to take your question all together at the end of the session. So I'd like to move on to the next speaker, who's Dr. Masaki Sato. He's the director of the Division of Obstetric Anesthesia at the National Center for Child Health and Development in Tokyo. He graduated from Hirosaki University School of Medicine, completed anesthesiology training at the National Center for Global Health and Medicine, and joined his current institution in 2011. From 2021 to 23, and he conducted research at Stanford University, United States, focusing on immunological responses in pregnancy-related complications and perioperative medicine. He still continues to corroborate research team in Stanford. His work aims to improve understanding and care in obstetric anesthesia. Today, his talk about, his title is Insights from U.S. Obstetric Anesthesia, Clinical and Research Perspective. Dr. Sato.
Hello, everyone. I'm Masaki Sato from National Center for Child Health and Development. I don't like this name. It's too long. Today, I would like to share some insights I gained during my training and research experience in the United States. I will first introduce the obstetric care and anesthesia system in the US, then talk about anesthesiology training, and finally present some example of our lab research at Stanford. I have no disclosure. Here, I want to give special thanks both Dr. Ayumi Maeda and Dr. Kazuo Ando, practicing physician in the U.S. They helped me a lot in preparing this presentation. I really appreciate their support. Let me briefly introduce Stanford University. Stanford has a very beautiful and very large campus. On the left, you can see the Oval and the Hoover Tower, which are iconic landmarks of Stanford. In the middle photo is Memorial Church, located at the center of campus. And on the right is the famous arcades, a long walkway with arch. Walking through the campus is always inspiring, and it was a great environment for study and research. If you have a chance, please visit. It's truly worth seeing. On this slide, I would like to explain some key points about medical care and anesthesia in the US. First, medical costs are very high. And the second, the insurance system is also complicated, and it is sometimes hard for patients to understand. Patients usually need to see a family doctor first, and it often takes a long time to meet a specialist. And actually, I couldn't meet a special doctor during my studying period. In some situations, surgeons hire anesthesiologists directly, and each doctors are highly specialized. Medical care is really centralized, and many hospitals focus on specific service. Finally, there are CRNAs, certificated nurse anesthetists, who also provide anesthesia care in the US. Here I show where women give birth in Japan and the US. In Japan, about half of delivery occur in hospital and about 45 take place in medical clinics. Only a very small number happen at home. In contrast, in the US, almost all births, about 98%, occur in hospitals. Deliveries in clinic at home are very rare. This difference reflects the more centralized obstetric care system in the US. As I mentioned on the previous slide, in Japan, about half of all births occur in small facilities with fewer than 500 deliveries per year, whereas in the US, only 8% of women give birth in such small facilities. This slide shows how obstetricians work in the US. In the US, obstetricians usually work in both clinic and hospitals, and perinatal and postpartum care are mainly done in clinics. When it is time for delivery, patients go to the affiliated hospital where the same obstetricians or their team provide care. This system allows community of care and makes it easier to manage emergency and high-risk cases. This slide shows the idea of centralization in obstetric care. Many small clinics send their pregnant patients to one main hospital for delivery. The clinic does the checkups, and the hospital handles the birth and emergency. With centralization, one hospital can support many clinics, and this helps improve safety and quality of care. But there is an advantage and disadvantage. First, the advantage was when many deliveries are gathered in one hospital, the hospital can keep enough staff and resources. It also allows obstetricians and anesthesiologists to stay in the hospital 24 hours, which makes care safer. Now, the disadvantage. Some women may not have a nearby place to give birth, and traveling to a central hospital can be difficult, especially when labor has already started. So centralization has clear definitions for safety, but it can also create challenges for access. And this slide shows the differences in delivery method between Japan and the US. The first, epidural use rate. In Japan, only about 40% of all births use epidural anesthesia. In the US, the rate is much higher, about 84% at major hospital. But please note that the 40% in Japan is based on all births, while the 84% in the US is based on only vaginal birth. Next, the cesarean delivery rate in Japan, C-section rate was about 24. In the US, it's higher. This figure compares the providers of labor analgesia in Japan and the US. In Japan, epidural analgesia is frequently performed by OB doctor, and only 37% is administered by anesthesiologist. But the data from Japan are based on the percentage of facilities, not the percentage of actual providers. Newer data show that the real number of anesthesiologists providing labor analgesia is higher than this data. This table shows how often anesthesiologists work in both the operating room and obstetric anesthesia, depending on the number of babies deliveries per year at the hospital in the US. In large hospital with 4,500 or more deliveries, only 11% of anesthesiologists work in both areas. On the other hand, for 500 to 1,500 deliveries, the dual practice rate rises to 68%. And this shows that the situation in Japan today was similar, very similar in the US in 1981. At that time, for labor analgesia, about 68% was provided by anesthesiologists or CRNAs, and about 30% was provided by OB doctor. For C-section, almost all anesthesia, about 92% was done by anesthesiologist or CRNA. I show how OB anesthesia has changed in the US. In 1981, 30% of epidurals were done by OB doctor. Today, epidurals are almost always provided by anesthesiologist or CRNA. At the same time, the number of birthing facilities also changed. These two changes happened together. As OB anesthesia became the job of specialists, care became more centralized, so OB anesthesia and the number of birth facilities are closely connected. This is a short summary of OB care in Japan and US. In the US, almost all deliveries have 24 hours anesthesiologist or coverage. This means an anesthesiologist is always available day and night. Second, in Japan, if anesthesiologists work both in the operating room and obstetrics, 24-hour coverage may become possible in the future. Finally, it is impossible to explain to the public the pros and cons of consolidating childbirth facilities in Japan, so everyone can understand the benefit and risk of the current system. This is the this slide shows anesthesiology training at Stanford. In year 1, residents work in internal medicine and surgery. And year 2 and 3, they worked as anesthesiologists with specialty, for example, cardiac, pediatric, or OB or pain, etc. After that, they can be attendant. I think attendant is the after. Sorry, no. There's a 150 people attendants in the Stanford University. And fellowship. What is fellowship? The most anesthesia fellowship last 1 year. Second, fellowship training makes it easier to find a job and attending. Third, some people do fellowship to focus on subspecialty. Fourth, some people want to do some research during or after fellowship. This slide shows the main features of the Stanford Anesthesiology Fellowship. And this shows how fellows do how fellow works at the university. Many studies are running, and they give strong they are given strong support from great teachers, and they can do basic research or a lot of things. And I'd like to summarize the anesthesia education. As you can see the slide, they takes maybe 3 or 4 times for a year to be specialized or be anesthesiologist. Next, I'd like to move on to the topics of research. This slide compares research funding in the US and Japan. As you can see, both countries have many. The US spent roughly 3 or 4 times more on university research funding. But the definition of research funding differs between the two countries. Both countries have many private grants, but the total amount is very different. I'd like to a little talk about my lab where I worked. The slide introduces my lab. The left photo is my team, and the man looks like actor is my boss. Sorry. And on the right is the overview of mass cytometry, which is our main research. Mass cytometry is a technology that measures many markers on single cell using metal tags. It's so difficult. I couldn't understand for now, but they can understand. So I skip them. This study is recently published from our lab to JAMA. We compared personalized rehabilitation and standard pre-rehabilitation before major surgery. The graph looks so difficult. It's difficult to understand. I don't know what this say, but the result is personalized pre-rehabilitation causes clearly immune changes. Standard pre-rehabilitation shows only small immune changes. On the other hand, personalized prehab reduce inflammatory signals. Even after finishing my training at Stanford, I continue to work together with my colleagues in Japan and the US. We organize joint research meeting and international symposium, and we keep developing new collaborative projects. This event helps us stay connected and continue our research partnership. Finally, I'd like to summarize the key points today's talk. I talked OB care in the US and anesthesiology education and research system in the US. Thank you for attention.
Thank you very much for your lecture, Dr. Sato. Now I'd like to introduce Dr. Shohei Noguchi. He's an instructor and fellowship director in obstetric anesthesia at Saitama Medical Center, Saitama Medical University. He is a very unique man, and he is dual trained in anesthesiology and obstetrics, and with interests in labor anesthesia, obstetric anesthesia, and maternal critical care, and perinatal safety. He completed an OB anesthesia fellowship at UZ Leuven, Belgium. He also contributed to the National Educational Guideline Committee in Japan. His publications span major journals in obstetric anesthesia and perinatal medicine, and he is the author of several books, including Amazon bestseller on labor anesthesia. In this lecture, he will share the future perspective of obstetric anesthesia in Japan. Dr. Noguchi, please.
Thank you for your introduction. So my name is Shohei Noguchi, and I'm from Saitama Medical Center. And today I will talk about the future perspectives of obstetric anesthesia in Japan. So here is my COI disclosure. So here is my outline. So first, I will talk about the current situation of obstetric anesthesia in Japan. So next, I will introduce our educational efforts in obstetric anesthesia. And finally, I will discuss how international academic exchange is helping us move from Japan to the global stage. So let me begin with the reality of obstetric anesthesia in Japan. So I will explain the current situation of obstetric anesthesia in Japan from the three perspectives. So anesthesia for cesarean delivery, maternal resuscitation, and labor analgesia. To begin cesarean section. So anesthesia for cesarean delivery is becoming increasingly standardized in the world. So as you can see here, you now have several consensus statements and guidelines. These documents will help you move towards safer and more consistent practice. And in recent years, you have also focused on how preoperative management can improve postpartum recovery. These efforts developed under the concept of enhanced recovery after cesarean. We call it ERAC. The ERAC recommendations were updated this year, so reflecting new evidence and clinical practice. So let's check it out. So in this context, our team, led by Dr. Yonekura, has attempted to describe the current practice of anesthesia for cesarean delivery in Japan. So our goal was to clearly document what is actually happening and to provide a foundation for future improvement. This study analyzed the current practice of general anesthesia for cesarean delivery in Japan from 2005 to 2020 using insurance claim database in Japan. So it found that general anesthesia with muscle reluctant and intratracheal intubation was used in only 3.9% of cesarean deliveries. And this study described the use of neuraxial morphine after cesarean delivery in Japan from 2005 to 2020 using the same nationwide insurance data. The overall use rate was 16%, and it's increased to about 30% by 2020. Surprisingly, continuous epidural local anesthetic infusion was used in 36% of cases. So this study surveyed perinatal centers in Japan and about the ultrasonic use during cesarean delivery. So okistocin was the first-line drug in 96% of facilities. So administration routes were IV only 44%, and intrauterine myometrial injection only 21%, and both 21%. So second-line drug were methyl-ergometrin, 75%, prostaglandin F2 alpha, 8%, and prostaglandin E1, 2%. So this study surveyed JSOP members about PONB prevention after cesarean delivery. Among responders, 63% used neuraxial opioids. In this group, 20 used 2 or more anti-amics for PONB prevention, compared to 6.7% in the non-neuraxial opioid group. Now, metoclopramide was the most commonly used agent, around 65%, and followed by 5-HT3 antagonists, around 15%. So here are the next challenges in improving anesthesia and preoperative care for cesarean delivery in Japan. So expanding the use of neuraxial morphine and multimodal postoperative analgesia, so promoting prophylactic continuous vasopressin infusion, establishing multimodal strategies for PONB prevention, optimizing the use of ultrasonic agents, and implementing enhanced recovery after cesarean protocols, and encouraging gentle cesarean delivery practice. And next, maternal life-saving. Among 559 maternal deaths in Japan from 2010 to 2022. So 7 cases were directly related to anesthesia, actually. So we all occurred in small facilities without anesthesiologist, include 3 cases of CICB, 3 high spinal blocks, and 1 case of local anesthetic toxicity. So lack of basis knowledge in airway management, anesthetic dosing, and the toxicity response were key points. The United Kingdom editorial from James Bamber commends Japan's national report on anesthesia-related maternal deaths as a crucial step forward. It highlights in the United Kingdom, similar audits helped reduce such deaths from 39 to under 4 per year. So the authors stress that safe obstetric anesthesia requires specialist anesthesiologists, not solo obstetricians, and that teamwork is essential. They end with a strong message like, the best maternal outcomes need the best anesthetic care. This editorial, written by the several Japanese anesthesiologists and Japanese doctor in the United States and Dr. William Kahn, highlight that around 40% of cesarean deliveries and 2/3 of labor analgesia cases in Japan are still managed by obstetricians. And this single provider model is rare internationally. The authors argue that safe childbirth requires system reform, centralizing delivery care and involving trained anesthesiologists. This editorial may sound crucial and critical, but I don't see it as a conflict. When something needs to change, outside voices and open discussion are important. I believe that now is the right time for countries to share ideas and speak honestly in academic settings. For maternal safety, we need to face the issue together with respect and collaboration. And going to next topic, labor analgesia. So in recent years, the demand for epidural labor analgesia has continued to rise in Japan. As you can see here, so its utilization rate has increased fivefold over the past 15 years. And this figure shows the regional utilization rates across all over Japanese prefectures. As you can see, the rates vary widely, from 0% to up to 31%, depending on the region. So this study, the birth database of the Japanese Ministry of Health, Labor and Welfare, the nationwide status of labor neurological anesthesia in Japan. So among 2,063 delivery facilities, 837 provide labor analgesia. 47% were hospitals and 53% were small facilities with fewer than 20 beds. And 27 registered a board-certified anesthesiologist as a responsible doctor, and many small facilities relied on the obstetricians to perform labor analgesia. Only 14 facilities offered 24-hour labor analgesia coverage, and the facilities led by anesthesiologists had even lower rates of 24-hour availability. And then I'm going to talk about the education effort of obstetric anesthesia in Japan. So the perinatal and obstetric anesthesia education guidelines were created jointly by JAPA and JSOP. We set learning goals and teaching standards for anesthesiologists involved in perinatal care. The guidelines focus on three main areas, as you can see here. So 16 core competencies, aiming to build not only medical knowledge and skills, but also teamwork and leadership. Training items are organized in levels, like level 1 to level 3, to support step-by-step learning. And this is the content of the guideline. So each item is clearly defined and organized by level, so it is easy to use in practice. So we'll also have an educational video series called Monthly Obstetric Anesthesia, produced by JSOP. So these are short videos, mainly for our members, released on Wednesdays, once or twice a 1 month. The series covers wide and range topic, from basic principles to recent updates, history, and even some trivia. Of course, all grounded in evidence-based practice. Our hope is to share the joy of obstetric anesthesia with as many as possible. So JSOP also provides public-facing educational content to improve health literacy about obstetric anesthesia. On our website, we offer the detailed Q&A on labor analgesia as shown. So written for pregnant women and their families in plain language explanation, all based on accurate evidence-based information. This is one way we try to support shared decision-making and help women choose their birth plan with reliable information. So finally, I will discuss how international academic exchange is helping us move from Japan to the global stage. So at Saitama Medical Center, our center, we collaborated with Stanford University to develop the Japanese version of postpartum recovery scale. We call it Obscure 10 Japanese, which can be used internationally. In this study, we prospectively compared postpartum recovery after cesarean delivery and after vaginal birth using this validated tool. So Obscure is a 10-item patient-reported questionnaire on postpartum recovery. So we have made the Japanese version openly available for researchers all over Japan. So if anyone here would like to use it, please let me know. So Japan is still developing a stage of labor analgesia, which means we have many unique comparison groups and great opportunity to high quality research, I guess. So together, we can share meaningful messages from Japan to the world. So you are not alone. So Japan certainly faces many problems, as you know, in obstetric anesthesia. But these problems are not only Japanese. So Belgium, other European countries, and even the United States struggle in their own ways. So when I was in Belgium, I learned from other fellows that, such as Greece fellow, still has many cesarean deliveries under general anesthesia. And Italy has few opportunity for epidurals. And some rural areas in Sweden face a serious risk because blood transfusion is not always available. Every country has its own difficulties. So this is why I believe it is important for Japan to share our reality with the world. Through open discussion and international exchange, we can find a better solution together. Real change always needs some inspiration and mixture from the outside. So let me end with a line from the recent editorial from the United Kingdom. Best maternal outcomes demand best possible care. That includes best anesthetic care. I believe this responds the future we must build for obstetric anesthesia in Japan. Thank you for your attention.
Thank you so much for the lecture and a strong message to the audience. Now we'd like to move to the discussion. And so could you come up to the stage speakers? And I also want to welcome Lisa Saishu, who's from the Leuven, and she's an anesthesia trainee. And she speaks Japanese, English, French, and Dutch. So she's going to help us translating questions and comments. So thank you so much. Questions from the audience. And so I'd like to take a question. Okay, the first question goes to Dr. Sato. I'd like to know if any research in obstetric anesthesia has been applied clinically.
Would you say that again?
And I'd like to know if any research in obstetric anesthesia has been applied clinically and changed your practice.
Yeah, at Stanford, some fellows did research about a PIAB program or solution or volume. After that, they got a good result, and they changed their protocol. Actually, so their research was very useful for their practice.
Okay, thank you. Then the second question goes to Dr. Debru. Well, in Japan, the delivery system is not centralized; they are scattered. And how is the situation in Belgium? What's the size of the delivery
Yeah, Belgium
institutions?
is a very small country. We only have 12 million people in Belgium, and we've got a lot of hospitals. So also, I think 98% of deliveries are performed in a hospital. And I think the biggest center is having about 6,000 deliveries a year, but it's also divided in different little hospitals around. So, but I think in 85% of all hospitals, there is an anesthetist in the hospital 24/7. And all anesthetists come out, so Sho knows, everybody has a basic training on obstetric anesthesia, should know the basics of obstetric anesthesia. So I think in 85% of cases, if a woman delivers in Belgium, she's got immediate access to obstetric care. So I think we're very fortunate. We're a high-income country, and all deliveries happen in hospital. So I think everybody's capable of. Sometimes they have to wait maybe half an hour. I think 20 minutes in the hospitals where there's nobody in the house for anesthesia, they have to be in the hospital within 20 minutes. So I think that's the longest a patient have to wait for an epidural.
Okay.
Yeah.
Thank you so much. Well, most of the patients wish to have epidural analgesia in your country. Am I right?
Yeah.
So what are the reasons if for the patients not having labor analgesia?
Some people just don't want to. They want to have a natural birth more. Some people are just too late. I know we do put in CSEs until 10 centimeters of dilation, but sometimes labor happens so fast that they're too late. Some people have medical problems that they cannot have epidurals when they're when they've got congenital clotting factor deficits or when they're on a medication, then they can't have epidurals. But most of the times when they're delivering without, it's because it's too fast or when it's a choice not having epidural during labor.
Fair enough.
Yeah,
Okay.
but I think in our hospital, 85% of women are having an epidural.
Right. Thank you. And the next question goes to Dr. Sato. In your talk, in 80s, obstetrician give labor analgesia to pituitines, but it changed to the anesthesiologist. So obstetricians do not provide analgesia anymore. And what do you think? Why do you think the change is made?
I'm sorry, I'm not sure about that, but maybe in 90s, some maternal deaths occurred after OB doctors provide. Do you know about that? No.
I think it's important that it's two different doctors. I think so, but I can understand if you've only one doctor available that it happened. But I think being an OB anesthesiologist is more than putting an epidural in. Is also taking care of all the consequences. If there's a high spinal, we know what to do. We can intubate. We can do I think having a technique to put an epidural in is one thing, and I think everybody can learn it. But dealing with the consequences when something goes wrong, I think that's where it is very important that an anesthesiologist should take care of those patients. And unless you're Shohei, who has got two complete trainings, I think it's safe that he puts an epidural in and he's taking care of cesarean section, but he can't do two things at the same time either. So that's why it's important that you've got two different doctors taking care of the patients. But I understand historically how it came. If you say, I can help this patient, but if you always have to balance safety with what you can give, and I think speaking of safety, it's not very good to have an obstetrician giving labor analgesia. That's my opinion. I don't know if there's other opinions.
How about Dr. Noguchi? Do you have any ideas?
So in my opinion, so it doesn't matter. So which should perform labor analgesia. So the best thing. So my comment is that message I said. So best maternal outcome needs best anesthetic care. So we need best physicians who can produce best anesthetic care. So I was like, we need education of obstetric anesthesia. So the problem in Japan now is that the lack of education of obstetric anesthesia, even among anesthesiologists, as you know. So we need to develop the education for obstetric anesthesia all over Japan.
Okay, thank you.
So, but not for the obstetricians. I don't think.
Right. In Belgium, Dr. Debreu, did you experience the same sort of transition period from obstetrician to anesthesiologist in terms of labor analgesia? No.
No.
So from
it was
the
an
beginning,
anesthesiologist from
all
the
time,
beginning.
From
yeah.
the beginning. Oh, okay.
Yeah, no.
Good. So, talking about education, what are the training systems like in Belgium?
We've got a continuous training system. They've got theoretical training and they've got on-hands training. And if we speak about obstetric anesthesia, it's not a separate specialty. It's just every trained anesthesiologist should have the basic principles. Of course, you've got people with more interest in obstetrics. They can do a fellowship like Shohei did with us. And we always have one fellow around who wants to be the lead in the hospital where they go to. I think in every hospital there is at least one anesthetist who makes sure that he keeps up with all the literature and he will teach his own people, look, this is new, we are going to use these pumps now, we are going to use this solution now, but it's not a separate specialty. It's not that you only can treat pregnant patients if you're an obstetric anesthetist. No, all anesthetists can do obstetrics. But I think it's very important, and we also advise every hospital to have one person that is dedicated to obstetric anesthesia and goes to the congresses and see if there's it's not a lot obstetric anesthesia. It's just keeping up your skills and being following the literature and make the little adjustments in time, not wait for 10 years and then say, okay, now I'm going to look what has changed. It's very important that at least in one department, there is one person who give updates to all of his colleagues. Look, everything is remained the same this year. You don't have to make any adjustments. Or maybe we should change this or this. I think that's important. In our training system, the first 3 years, our trainees don't come on the obstetric ward at all. So they have got their basic training in local regional anesthesia, general anesthesia, before they come to the labor ward. So they don't have to learn the technique of a CSE anymore. They've learned it in the general OR, and only then they can approach pregnant patients, because we don't think it's like the learning material. If they're moving targets, it's not the best way to learn the techniques. So they should have known the techniques before, and then they come to the labor ward to just teach how, that we can teach them how to look after a pregnant patient, because it is different. It is always a situation that a woman never has been in before, or maybe once or twice. Very important.
Thank you. So, in average, how many cases of labor analgesia the trainee can experience during their residency? How many cases?
Yeah. In their training, they should have at least 50 cesarean sections. And I don't know if there's any number of labor epidurals, but they have like they will stay in our labor ward at least 1 month. And during 2 years, they're doing older on calls also on the labor ward. So they've got quite a lot of exposure. I don't know the numbers, just the numbers, but they should have at least 50 cesarean sections.
Okay, thank you. So the same question goes to Dr. Sato. I remember you mentioned about training system in the United States. Mm-hmm. Can you explain it once more to the audience and to me?
No. In the U.S., they have three years residency and 1 year fellowship, and during the residency period, they can choose. It's only I only know at Stanford. Sorry, but they can choose the OB, and they have to train in OB anesthesia, maybe more than 3 months or 6 months. They're in 3 years, and the doctor who want to be OB anesthesiologist go to the fellowship in OB team.
Okay, thank you. And the next question is about the training for the midwives and the nurses in the OB ward. Do you have sort of education system in Belgium for the midwives?
Midwifery is 4 years in Belgium, so
yes,
and they've got
for labor anesthesia. I mean,
yeah, they've got their whole training is 4 years, and they've got few lessons of it. I give like 6 hours. I go to the midwifery school and give 6 hours about labor analgesia. And then they're trained in the hospital when they do their rotas, their rotations. They will be taught how to assist with labor epidural or also cesarean sections and things. I think there is there is room for improvement, because I think our midwives, our starting midwives, are not very able to assist and to notice all the difference and the complications with epidurals. There is still room for improvement, but it has changed, because I think 7 or 10 years ago, in Belgium, you used to be a nurse and then you specialized in midwifery. Now it's from the start you choose for midwifery. And I think the nurses were better trained. And then because they had a more holistic view on the patients, they knew more about hemodynamics, they knew more about everything. And now they're really focused on being a midwife from the start. They're looking more at, it used to be 5 years and now it's 4 years. So I think there is some room for improvement in their anesthetic care for us, to help us.
Thank you. Do you have CRNAs in Belgium? The nurse anesthetists?
Nurse anesthetists, no, we don't have them. No.
Okay, thank you.
We've got nurses that help us, but we don't have dedicated, no.
Thank you. And the question to Dr. Sato, the same one, the education system for labor anesthesia for the midwives and the nurses.
Unfortunately, I haven't talked to midwives in the hospital, so I'm not sure.
You're a dedicated researcher, right? Yeah. Thank you. Okay, the next. Can anybody wants to answer the question or?
So I think one of the questions here is, how do you think, Professor De Roux, we can increase the proportion of anesthesiologists handling obstetric anesthesia in Japan?
Are there enough anesthetists in Japan? Are there enough to provide already surgery? No. Are you working with nurses that can cover you as well? So, no. And is the surgery hospitals the same hospitals than the maternity hospitals? That are the same. It's the same hospital. Yeah. Then I think, and can you leave a room if you're doing, for example, surgical lists, you're doing, I will say you're doing urology lists, and they call you to go to maternity. Is there somebody who can cover you for the while you're gone or not?
It can be possible. Well, it is possible, but not always.
Yeah, is the law accepting that, for example, a nurse comes for a short while, for 15 minutes, comes into your room while you go and put an epidural and then come back? That's how it's organized in the smaller hospitals in Belgium. Then there will be somebody, you're doing surgery, and they will look, this surgery, this theater is a stable anesthesia. They will call in a nurse that can observe the parameters for a short while, like 15 or 20 minutes. Then the anesthetist goes to the labor ward, put in an epidural, wait until it's working, and come back to the surgery. That's how it used to work in Belgium. It's not completely allowed anymore, but that's how it works. That somebody takes over for a short while, that everything remains safe in the operating room, and then the anesthetist goes to the labor ward, put in epidurals, and come back. And that's how it used to be in our hospital as well.
Thank you. Do you have any ideas, Dr. Noguchi, to increase the proportion of anesthesiologists to engaged to, yes.
So as you know, Japanese anesthesiologists have to do more things. So actually in Belgium, the anesthesiologists cover the anesthesiology for endoscopy as well. Yeah. But actually in Japan, no. Yeah. So any surgeon or internal medicine physician perform sedation and analgesia for endoscopy, right? So so totally lack of anesthesiologists in here. So, so it's very difficult. So the key point is, I guess, task shift, right? So as Sarah said, sometimes clinical nurse can help us, and sometimes the surgeon or obstetrician can help us. So we need collaboration, and during that period, we need to increase the education and increase the number of practitioners for obstetric anesthesia as well at the same time. That is a best solution for us.
Yeah, I think it's very important that you keep in mind safety. Safety becomes before everything. We know that for patients having severe maternal morbidity, we know that an epidural is providing an epidural will increase safety for those sick persons. But I can imagine if you've got a completely healthy parturient, giving an unsafe epidural is more dangerous. So I think if you want to increase your labor analgesia rate, you must make sure that it is safe and that there is somebody that can handle a high spinal block, that can handle anaphylaxis, that can handle all kind of trouble that can come with an epidural. So that is important, that you don't put healthy patients in danger. But I think for more patients that have already some pathology, it is very important that you can offer labor analgesia. Maybe in the beginning when there is not enough obstetric anesthetists, you have to make a choice in who will get one and who will not get one to balance safety and better care. I think that's important.
I think there's another interesting question here from the audience, which is, do we have any regulations concerning fasting before putting an epidural when parturients?
There are no, in Belgium, they don't have to be fasted during labor, no. I'd rather have it sometimes. I never advise to have a full meal, but it's very, I know our midwives are just saying, look, if you don't feel like eating, just keep on drinking and drinking isotonic sport drinks and things like that. That's our advice. But there are no clear rules and there are no laws to say that they can't eat. And I know it's a very cultural thing. If you've got in some culture, it's very important that they keep on eating. But I think it's very smart if you're in labor not to eat too much because it saves you a lot of trouble.
Yes, thank you. So the last question goes to Dr. Debru. And do you have any comments for spinal analgesia? Continuous spinal analgesia for the obese, super obese patients.
Super obese. I know that's a discussion that goes on and on and on. I think, but I think it has been said that it is easier to have a continuous spinal anesthesia for a few reasons, because you know for sure where it is. You can always check if you still can get some CSF back, then you know that you're still in the spinal space. And they also say that obese patients don't have as much PDPH as have other lean patients. But I think I would always go for epidural, still go for epidural and not go for continuous spinal. And we've got like a WhatsApp group with a lot of obstetric anesthetists over the world. And just yesterday, there was a question coming in with asking for a patient with a BMI of 100, 100, so that's a lot. And in our consensus, we said, first try for epidural and probably it will be okay. And they managed to have just the epidural and it was all right. So no, I would not be pro a continuous spinal.
Okay.
How about, How about after accidental dural puncture?
In our hospital, Sho knows it, after an accidental dural puncture, we use the spinal catheter. We use it for labor analgesia and we use it for cesarean section, because we think the hole is already there. Our institution knows how to manage. I will not say that it is, and definitely not if there's not obstetric anesthetist available 24/7, I would never recommend using a spinal catheter. But if people that know what it means to have a spinal catheter are around, you can easily use it, because we do know that if you have to reposition your epidural, then you can have another accidental dural puncture and you get into trouble more. But I must say, I don't think a continuous spinal in Japan will be the first thing to do. I think first get some labor analgesia everywhere and not start with the spinals yet, because you really need people that know what to do if you've got a spinal catheter. It can be really dangerous.
Okay, thank you so much. Now it's time to close this session. Thank you so much for wonderful contribution, speakers, and Lisa, and the audience. We learned a lot from each other as we aim to do so. I hope this session will help us to reshape the future of obstetric anesthesia and enhance your practice in your own institution. Thank you so much, and please give big hands to the speakers and audience.
ご講演いただきました加藤先生、サラ先生、佐藤先生、野口先生、ありがとうございました。これをもちましてランチョンシンポジウムを終了させていただきます。恐れ入りますが、ご記入いただきましたアンケートは出口で係の者にお渡しください。本日はご参加いただき誠にありがとうございました。